Good day and welcome to today's presentation. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Lisa Sullivan. Please go ahead.
Good afternoon. We are very pleased to have you joining us today for the Comprehensive National Nursing Home Training. And this is the fifth and final time this training will be offered live. My name is Lisa Sullivan and I am looking forward to a wonderful event today. Just a few reminders before we get started. First, thank you for taking the time to be with us here today. The slides and recording from today's session will be posted to the QIO program website. During the open question period, please keep in mind that we will get to as many questions and comments as time permits. But if there are any unanswered questions, we will address those as well post-event. Along with our speakers today, we also have CDC colleagues and colleagues from Centers for Medicare and Medicaid Services, Department of Nursing Homes, to answer questions with us. I want to thank all of our colleagues for being available to assist us during the question and answer portion of today's event. Please also note that we will have a post-event survey that will be shared via a link during question and answer period. You will also have an opportunity to complete the post-event survey immediately following the conclusion of today's training. Please do complete the survey. We value your feedback on how we can make these and other training opportunities better. Next slide, please. I'd like to introduce our speakers for today. We have four impressive speakers here to present, and they are Eli DeLille, Deb Smith, Dr. Kimberly Rask, and Susan Purcell. Our first speaker will be Eli DeLille from HSAG. Mr. DeLille serves as an infection preventionist with more than 16 years of experience in the healthcare industry with expertise in quality improvement, analysis and implementation of performance improvement, patient safety initiatives, and direct patient care. Mr. DeLille earned a master's degree in nursing from Marshall University. He is certified in infection control and is a fellow with the Association of Professionals in Infection Control and Epidemiology. I would now like to turn the call over to Eli DeLille. Eli, the virtual floor is yours.
Thank you, Lisa. I appreciate the introduction as well as the opportunity to present today. Next slide, please. I'm going to be covering how to establish an infection prevention program as well as conduct ongoing IP surveillance in the nursing home. Next slide, please. Some key elements of infection prevention include developing a system for preventing, identifying, reporting, investigating, and controlling infection and communicable diseases for all residents, staff members, and visitors. And as the U.S. approaches 3.9 million COVID-19 infections with over 143,000 deaths impacting our elderly, our infirm, and many others, we want to make sure that we give this the level of priority that it needs. We want to make sure that we establish goals and priorities for your program, as well as plan and implement strategies to achieve those goals, monitor compliance, as well as respond to identified issues as they develop. Next slide. I can't really talk about infection prevention in the nursing home or anywhere without focusing on the importance of training and education for the new infection preventionists or even the seasoned one that may not have realized the scope of this role prior to COVID-19. So the designated infection prevention lead should complete the CDC infection prevention training. This course is self-paced. It's made for the working staff member, and it's a series of 19 different modules. Some of them are 15 minutes long, others are a little bit longer, but it's made so that even the busiest infection preventionists can find the time to take the course. Next slide, please. And as good as the CDC training is, it really doesn't perfectly prepare that new infection preventionist. So you want to make sure that you still allocate the time necessary for them to become familiar with your facility, your policies, your emergency preparedness plan, so they can really operate to the fullest extent of their ability. What we did at HSAG is we have close to 50 years of infection prevention experience between 4 staff members. So we sat down and developed a tool to help standardize the approach to infection prevention. It ensures some consistency, so whether you're a nursing home that's COVID naive with 1 full-time staff member and plenty of personal protective equipment, or you're that person that's trying to split the role between 3 people with 1 person identified as that primary lead, you can answer questions consistently between whoever is filling that role. There's a defined criteria that both nursing home administrators as well as surveyors like, because as you look at how you are oriented to your particular facility, you can pull this out and show over time that you took the additional steps necessary to make sure that your infection preventionist was successful in this very crucial role. Next slide, please. Once you've got that fundamental knowledge, you're ready to go out and start seeing if there's an opportunity or a gap between your policy expectations and what's actually occurring within the unit or processes. There's a great tool out there. There's a full ICAR assessment or infection control assessment from the CDC that looks at your entire nursing home program. But if you're faced with a pandemic like we are, you might want to focus your efforts on looking at those processes around your highest risk priority of opportunity, which would be COVID-19. This assessment was initially created by 4 public health officials to do with nursing homes. What we've discovered is the perfect self-assessment for a nursing home as well. It runs through 5 defined areas, which are going to be covered further throughout this presentation, but I highly recommend taking this tool if you haven't seen it yet, looking at after this presentation, and taking it out to the unit to see if there's any opportunities you can immediately identify. Next slide, please. Once you have your plan, and you have, your assessment, you have to develop a plan. You have a better idea now of what your opportunities are, but you need to put that basically down on paper. Having an idea or direction right now could lead to confusion, and everybody has to be on the same page. As an infection preventionist, it's really important to make sure that you identify what factors contributed to your assessment findings. So it could be your survey report, your own COVID-19 assessment, or an outside agency coming in. You want to make sure that you list your best practices. We have some major ones listed here from the CDC, but you have to tailor those to fit your local health department or your state health department needs. In California, we're fortunate to have a mitigation plan requirement, and a lot is dictated by the state health department on what actions to take, and each facility is expected to have some customized version of that tool. You need to make sure that you let people know who is responsible for the plan. An infection preventionist is always going to be listed, but they do not have ultimate authority over the building. You need to make sure that your director of nursing, your ADON, your administrator are key partners in this, and you really can't be successful without their support. You need a date started so you can correlate this. Let's say you're seeing in your outcome measures, your NHSN reporting, an increase in staff COVID-19. Well, we know that an easy way for COVID to get introduced into a building is staff working, not having good process measures with their residents, and then transmitting that infection to the resident. So you want to make sure that you have a clear timeline so that you could see where the new cases started. You implemented, let's say, source control, hand hygiene, environmental cleaning, isolation precautions, monitoring with feedback, and then you saw a subsequent decrease in your NHSN reported COVID-19 infections. And ongoing compliance monitoring is especially important. As I mentioned before, we're reporting in NHSN now, the federal government, state governments, the quality improvement organizations, we're all using this data to kind of target who needs help the most. So you want to make sure that the data is accurate, but then also you need to be tracking and trending that over time. And if you do see an increase, we need to immediately start shoring up those infection prevention practices that may need some additional attention. And then finally, you have to be tied into your QAPI group. I know everyone is stressed right now. It's easy to neglect those meetings, but we have to make sure that we're still coming together as a team and seeing how we're performing. COVID is, of course, taken the forefront of all of our thoughts, but there's other healthcare-associated infections that are still occurring that we as infection preventionists need to make sure that are under control. Next slide, please. You cannot create an infection prevention plan in a silo. Early on in my career, I made the mistake of doing that and failed miserably the first time I tried to roll out a project. So it may seem like an unnecessary step, but bringing these people together and just getting their buy-in is going to give you some advocates, some champions to help you push your initiatives and the rationale behind what you're asking them to do. And that's where it goes to staff expectations regarding care. I think often right now, especially as the recommendations are changing, we're telling the staff what to do all the time. Well, that gets overwhelming. If we don't understand why we're changing, it's easy to become disillusioned or not follow that latest recommendation. So we always have to make sure we're clear on the rationale. You want to empower staff to speak up if they identify a concern. And infection preventionists cannot be everywhere at all times to everyone. So creating those champions, making sure that if they have a concern, they can come to you in a non-punitive way, and that you will take their recommendation or their concern and do action upon it to correct it. As I mentioned before, you want to engage your staff, your providers, and especially your residents in your infection prevention practices. A lot of people question like the resident portion of this, but we're asking them to mask up if they're leaving their room, to sanitize their hands more frequently, to separate themselves from their friends, their family. So making sure they're an active participant in our COVID-19 mitigation efforts is a really important strategy. And then never be afraid to come back and modify that plan. I think as infection preventionists, we have ownership of what we create. We hope that we always have the latest recommendations, but they're changing so frequently. We have to keep our fingers really on the pulse of the state, local, and CDC recommendations so that we can shift quickly and educate our staff regarding expectations. Next slide, please. As I mentioned before, we don't want to become so focused on COVID that we forget about some of the other areas of opportunity. So here's some links to several different infection prevention plans that we've created for our partners. These will be available in the chat as well as via a link in the PowerPoint presentation after. And then there's also an orientation checklist, but then if you have multiple opportunities, we included a risk assessment that you can look at the different opportunities and figure out which one you need to prioritize first. Next slide, please. And then next slide. Unfortunately, iPro couldn't be here today, so I was asked to present on their behalf, and I'm going to talk about COVID-19 surveillance as well as early detection. Next slide, please. iPro focused on the CDC's 3 key steps of keeping COVID out, really. We want to detect cases quickly and then also stop the transmission of COVID-19. Next slide. And their focus really was about giving actionable examples for you to take back and look to see if you may have similar opportunities or concerns within your own facility. So the first one with keeping COVID out, we want to do effective screening, and we want to manage staff at the door. And that includes wellness checks for all those entering the building. And this is not just, have you had any symptoms of COVID? Because often what we're finding is staff don't know just how comprehensive those symptoms are. So we need to make sure that we're asking questions rather than just kind of closing it down. You want to look at checking staff mid-shift because the course of the illness can change so quickly. Someone can come in on mid-shift or at the beginning of their shift and then start to develop symptoms, and they need to feel comfortable coming to you and saying, I'm starting to feel stuffy, I've got this cough, I just can't seem to catch my breath. You also want to self-assess at the end of the shift. Unfortunately, right now, we know staffing is a crunch pretty well across the country. And if you have a staff member that at the end of their shift, they're scheduled for the next day, it's going to be very difficult to cover for them. So they need to feel comfortable once again to let you know that there's a good chance they may not be there on a subsequent day. Well-trained non-direct care staff members can help with the screening at the door. It's also a great time to give your staff communication regarding changes in expectations of care. Everyone's funneling through the same place, so if you need to give handouts or a brief education session, it's a great time to catch them as they're walking in. And then you also want to make sure that you're maintaining that social distance from one another. The 6 foot is a very important COVID-19 mitigation strategy. So that includes at the beginning of your shift, in break rooms, and nurses station. To the extent possible, we need to make sure that we're respecting that. Next slide, please. As an organization, you need to make sure that your staff feel comfortable letting you know when they're too ill to work or they've tested positive or they had an exposure. We need to make sure that we're not pressuring them to come to work when they shouldn't, but also that they don't come back too early as well. I mentioned before that we have to kind of think outside of the box in our approach right now. So you may be a facility that's accustomed to 8-hour shifts that all of a sudden have to shift to those 12-hour shifts. And if they're working those extended periods, we need to make sure that we're assessing more frequently to make sure there's no changes in condition with our staff during the course of the day. If you have agency staff or people coming in and working multiple buildings, we need to make sure we know who those people are. I know in one instance in California, we had a staff member that was working in 3 different buildings. 2 of them were outbreak situations. The third one was still COVID naive. The COVID naive facility approached that person and said, we really need you to pick where you're going to work because we feel like you're bringing some risk, especially when you're working 2 shifts a day. So know who those staff members are and then have a plan to address that. And you want to make sure that you're prepared for those staffing shortages. It's a very fast-paced reality that many facilities are facing. In California, once again, we had a facility that was fine one day. Due to staff call-offs the following day, they ended up having an evacuation situation, and nobody wants to face that. So at least I know in many instances we're looking to volunteers and others to help fill that gap, and we have retired physicians, nurses, infection preventionists coming out of retirement to help as volunteers. So work with your local and state health department to determine who those volunteers are or those other people that can help fill your needs within your facility. Next slide, please. Once again, communication is extremely important. Technology right now is amazing, and we have to make sure that we're using it to the fullest extent. We have facilities that are doing weekly, question and answer session with families, or they're setting up Zoom webinars with their residents and their families just to keep everyone connected, or they do mass emails to their staff to let them know if there's been a change over the weekend or through the night. So making sure that we're capitalizing on technology as much as possible is important during this time. Another opportunity we've seen is limiting vendor access. As we limit visitors, this also means that your food delivery drivers, your medication supplies, your pharmacy techs, the staff members that are going from building to building definitely carry an inherent risk. So we need to make sure that if they are coming in, we're limiting it as much as possible. But if they do come in, that they're doing source control, hand hygiene, isolation compliance, your expectations within that facility. And then have a clear return to work policy. I know that right now, as I mentioned, staffing is a crunch, but when you have staff members off, we also have to be clear when they can come back. And there's a lot of confusion with local, state recommendations on when that can occur. So make sure you're very, very clear with your local jurisdiction when your staff can come back to work, so we're not extending that shortage any longer than necessary. Next slide, please. As you're looking at your resident population in step 2, it comes down to really detecting cases quickly in residents. And I'm not going to go too far into testing here, but I am going to go a little in detail about screening. And that's making sure that you're doing more frequent rounds with your residents. We have many nursing homes that are going to 1 to 2 hour per shift vital signs just because it is so quickly progressing within the post-acute population. You want to make sure that you're meeting more frequently, not just with your clinical staff, but with your interdisciplinary team, so that everyone is very clear regarding expectations and when a concern needs to be escalated. Appetite, cough, fall risk, other issues. We all know that the signs and symptoms of COVID-19 in the elderly population are extremely subtle. So you want to make sure you're having those frequent huddles to see if there is that little bit of that small change. And when you're doing those huddles, that's also a great time as an infection preventionist to kind of walk around and take a look for your administrator, for your director of nursing to make sure that people are being compliant for those process measures. And then I've been a nurse now for, I think, 17 years. It seems like much shorter than that, but it's been a long time. And you want to make sure that you go back to your basics with good assessment skills right now. It's that subtle signs and symptoms that gets you to identify quickly that this resident needs to be tested, that they need to be moved into isolation precautions, that's going to prevent unnecessary exposure to your asymptomatic negative residents and staff members. Remember, empower your staff to speak up and to let you know when they identify a concern. Next slide, please. And finally, we're going to talk about stopping transmission, and that's really what this entire webinar today is about. As we're washing our own hands, we want to make sure that we're washing the resident hands. As things are moving from one area to another, Deb's going to talk about the importance of cleaning, making sure that we're using an EPA-registered disinfectant for those items. They have chest pieces mentioned here, but another home tied an outbreak just to the bladder scanner that was going from one area to the next. So make sure that you're following the recommendations for cleaning. You also want to engage your residents as much as possible. As I mentioned before, we're asking them to wear a mask. We're asking them to wash their hands, to socially isolate themselves. The more that they know that they're a hero too, that they're a member of the team, and that they're protecting others as well as you, is really going to engage them in the process, because we know that keeping them as part of the team is such an important approach. Next slide, please. iPro included some resources here that includes a testing algorithm from ACA. I encourage you to check them all out. The CDC interim testing guidance, as well as their isolation guidance, changed just this past Friday. So if you haven't seen that yet, we're going to post those links at the end of this presentation. Next slide, please. And I want to thank Marguerite and David for the opportunity to present on their behalf today. I'm going to turn it back to Lisa.
Thanks, Eli. Next slide, please. It is now my pleasure to introduce Deb Smith from Health Quality Innovators. Ms. Smith has more than 20 years of experience as an infection preventionist. registered nurse, and ASCP, registered microbiology technician. Ms. Smith is a member of the Virginia chapter of APIC. Ms. Smith holds her certification in infection control, and she is certified professional in health care quality. Deb, the floor is yours.
Thank you, Lisa. And good afternoon, everyone. Thanks for getting on the call and taking time to be with us today. Next slide, please. My topic for today's training is cohorting as a core intervention of an infection prevention program, and it's currently being utilized during the COVID-19 pandemic. Next slide, please. Cohorting. The goal of cohorting or isolation is to prevent the transmission of microorganisms from infected, colonized, and/or asymptomatic residents to other residents, staff, or visitors who may in turn transmit them to others or become infected themselves or colonized. Residents infected or colonized with the same infectious agent can be cohorted together to prevent spreading that infection to other non-infected residents. Staff are also included in cohorting during outbreak situations like the COVID-19 pandemic to a specific cohort of infected residents, which further limits the risk of spreading infection in the facility. Next slide, please. To contain disease during the COVID-19 pandemic, the CDC outlines a plan for nursing homes to create a COVID care unit in their facility that can be dedicated to care for residents with confirmed COVID-19. This COVID care unit should be physically separated from the rest of the facility and be in place before the first suspected or confirmed COVID-19 cases. The COVID care unit can be a dedicated floor, unit, or wing in the facility, or a group of rooms at the end of the unit as long as it's separated by a barrier, and it'll be used to cohort residents with COVID-19. Nursing staff should be dedicated to work on these COVID care units when it is in use. If ancillary staff cannot be dedicated to the COVID care unit, they should be restricted from entering the unit. Next slide, please. There should be posted signage at the entrance to the COVID care unit instructing everyone who enters the unit to wear eye protection and an N95 or higher level respirator at all times while on the unit. Following the CDC's PPE optimization strategy, a face mask can be used when respirators are unavailable, but cloth face coverings are not considered PPE and should not be worn when PPE is indicated. Gowns and gloves should be added when entering resident rooms to perform resident care. Provide infection prevention training that includes the use of and steps to properly put on and remove recommended personal protective equipment. Resident care equipment should be assigned and dedicated to the COVID care unit. Cleaning and disinfection of shared equipment should be performed between resident care, and that equipment shouldn't leave the COVID care unit. Next slide, please. Assess your on-site and remote staffing capabilities to assure that you have adequate clinical and non-clinical staff with the required training, skills, and competencies in place when staffing the COVID care unit. These assigned and cohorted staff should not work across other units, floors, or facilities. If your facility doesn't have enough ancillary staff to dedicate to the COVID care unit, nursing staff may need to perform other duties like housekeeping or dietary tasks, so they need extra education in these areas. Whenever possible, it's recommended that nursing homes integrate consistent assignment of staff to specific residents, with the goal being to decrease the number of staff and resident interactions. Staff access between the COVID unit and the rest of the facility should be limited as much as possible. This can be accomplished by providing a separate entrance and dedicating break areas and supply rooms for the COVID care cohorted staff. Next slide, please. Keeping the resident and the family informed of the cohorting process is the first step in managing a resident with COVID-19 symptoms. Residents in the facility who develop symptoms consistent with COVID-19 should be prioritized for testing and moved to a single room pending the results of that testing. They should not be placed in a room with a new admission, nor should they be moved to the COVID care unit yet until they are confirmed to have COVID-19 by testing. Roommates of residents with confirmed COVID-19 may be exposed and should be considered infectious and moved to a single room or observation area. You can cohort potentially exposed residents in an observation area if single rooms are not available. Residents with known or suspected COVID-19 should be cared for using all recommended PPE, which includes the use of an N95 or higher level respirator, eye protection, gloves, and gown. Next slide, please. If your facility is receiving new admissions or readmissions who have been confirmed to have COVID-19, you'll need to carefully assess each resident for placement in your facility. If criteria for discontinuation of transient precautions has not been met, they will need to be admitted to the COVID care unit. If they have met the criteria for discontinuation of precautions, they can be admitted to the regular unit. When admitting residents with unknown COVID-19 status, they would not be cohorted on the COVID care unit, but they would be placed in a single room or in a separate observation area so the resident can be monitored for evidence of COVID-19. Staff should wear all recommended COVID-19 PPE when caring for these residents. Residents can be transferred out of the observation area to the main facility if they remain afebrile and without symptoms for 14 days after their admission. Next slide, please. Continue transmission precautions and cohorting for all symptomatic and asymptomatic COVID-19 positive residents until criteria for discontinuation is met. So the criteria on this slide are the CDC recommended strategies for discontinuation of precautions for symptomatic and asymptomatic residents. It's important to remember that if your state or local regulations are stricter and include a longer duration, you will follow those stricter regulations. If a symptomatic resident declines or is unable to be tested, you will continue transmission-based precautions until the symptom-based criteria are met. Next slide, please. Finally, contaminated healthcare facility surfaces play an important role in the transmission of microorganisms, including COVID-19. Therefore, appropriate cleaning and disinfection of surfaces and equipment which residents and staff touch is necessary to reduce exposure and minimize the risk of cross-infection from one person or object to another. Environmental cleaning during COVID-19, especially on the COVID care unit, should be enhanced and include at the minimum daily cleaning of all high-touch surfaces more frequently. Refer to the list of approved disinfectants to assure that your facility is using the right product in the correct way, paying close attention to the recommended dwell time, which is the amount of time a disinfectant must remain wet on the surface to work properly. Next slide, please. In closing today, I'd like to mention that each of your facilities are unique and you may need to adapt these recommendations to your facility. These adaptations will rely on your access to PPE, available space for the COVID care unit, the number of positive COVID residents you currently have. You can always reach out to your QIN/QIO or your state or local health department for assistance with any unique situation you encounter. So thank you for your time today. My contact information is here, and I'm going to turn the program back to Lisa.
Thanks, Deb. Next slide, please. I would now like to introduce our next speaker, Dr. Kimberly Rask, Chief Data Officer from Alliant Quality. Dr. Rask has provided clinical and analytical direction for economic evaluations, patient safety initiatives, and quality data reporting. A primary care physician and health economist, Dr. Rask also holds academic appointments with her research focusing on quality improvement and outcomes measurement with particular attention to rural and underserved populations. Dr. Rask, you are welcome to begin.
Thank you, Lisa. Today we're going to cover three important aspects of clinical care for COVID-positive residents. First, residents with COVID can have very different experiences with the disease. Second, it is important to have care plans in place that align with your residents' goals and preferences. And third, it's important to work with your medical directors to make sure that necessary medications are available when they're needed. As you know, COVID-19 is a new infection to us, and we're continuing to learn more as time goes on. We believe that most residents will develop symptoms within 2 to 14 days after being exposed to the virus. What is changing is that early on we focused more upon respiratory symptoms from COVID: fever, chills, cough, difficulty breathing, sore throat, or runny nose. And over time, we are recognizing that the symptoms can be much less specific. Residents may have headaches or tiredness, muscle aches, loss of taste or smell, or maybe no symptoms at all. Whereas we used to think of COVID as a respiratory disease, we're now thinking of it as a blood vessel disease. And that means that COVID-related symptoms are actually much broader and may not be very specific, as several of the previous speakers have noted. If we think about the clinical course for a resident who may develop COVID, we see large differences in their disease trajectory. Some residents will have no symptoms at all. Some will have only minor symptoms, and some will have minor symptoms for a week or two and then very suddenly become critically ill. And that is why the other speakers have noted, and the Centers for Disease Control recommends more frequent monitoring of residents with COVID, even if they have no symptoms or very mild symptoms. Next slide. Next slide, please. The other thing that we're learning over time is that many residents will not have any of the classic COVID symptoms. Instead, it's very common to see residents that only have subtle or nonspecific symptoms, like feeling tired, not being as alert as usual, slowly eating and drinking less. There may be a very slow downhill course over several weeks, and the changes may be very subtle. That's why it's important that staff be very familiar with the residents that they care for. In these chaotic times with staff changes, resident cohorting, there may be many different staff members caring for any individual resident. And because of this, it's crucial that staff have good communication strategies to make sure that any subtle changes in resident well-being can be identified, monitored, and shared with other staff caring for that resident. We're also finding that COVID is associated with blood clots and strokes. This means that some residents may develop altered mental status as their main or only COVID symptom. Next slide. Now we move to our second point, making sure that appropriate care plans are in place to respect resident goals and preferences. Advanced care planning is important for all residents, but it's particularly important in the era of COVID. As we noted earlier, some residents with COVID will have minor symptoms for several days or weeks and then suddenly become acutely ill. It is really important to have conversations about care preferences and to document those preferences long before a resident becomes sick, and decisions have to be made quickly when they're critically ill. The main question here is whether the resident wants to be transferred to the hospital. As you know, at this time, we do not have an effective treatment for mild or moderate COVID. What we can do is to provide supportive care as the virus runs its course. And much of this supportive care can be offered in a nursing home setting or in a hospital setting. Ventilator support is available in a hospital, but the experience from this spring shows that there is a very high mortality rate for older persons who are put on ventilators. The mortality rate for older people over the age of 80 was in excess of 80%, and the mortality rate approached 75% for those who were younger than 80 but with underlying medical conditions. Residents and their families need to be aware of this as they do advanced care planning. Advanced care planning ensures that the resident's care preferences can be honored if a health crisis develops. Next slide, please. Finally, it's important to work with your medical directors to make sure that all necessary medications are available for any of your residents who need symptom relief with COVID. Consider having standing orders for Tylenol, supplemental oxygen, and discontinuing any non-essential medications. Be sure that staff is trained as to the proper resident positioning to improve breathing, or what we call proning. Change nebulizers to meter-dose inhalers if possible to decrease the risk of COVID transmission from an infected resident to staff. And be sure that concentrated opioids are available in case it is needed for severe shortness of breath symptoms. If a resident is in distress, you do not want them to have to wait several hours until a medication can be made available from the pharmacy. And finally, I want to point you to the CDC resource at this link. It's a comprehensive source of information about how to evaluate and manage residents with symptoms of COVID-19, and the information is updated frequently as we continue to learn more about this disease. Thank you, and I will turn it back over to Lisa.
Thanks, Dr. Rask. As a reminder, if you have any questions, go ahead and click on the Q&A button at the bottom of your screen and type them in. So we'll have them when we begin the Q&A portion of today's presentation. Next slide, please. It is now my pleasure to introduce Susan Purcell from TMF Quality Innovation Network. Ms. Purcell has been a registered nurse for 34 years, working in critical care, home health, hospice, and nursing management. Ms. Purcell has been with the QIO for over 16 years, leading quality improvement projects in case review, nursing homes, hospitals, and outpatient settings. Susan, the floor is yours.
Hello, everyone, and thank you, Lisa. And thank you to Telegen, the Quinn QIO, who originally authored this presentation. Next slide. The objectives of the PPE presentation is to provide you with why and how to use PPE and give you links and resources that can be helpful. You will see that I've included numerous links throughout the slides for more in-depth information, and there's information in the chat about attaining the slides. Next slide. PPE is specialized clothing or equipment worn by an employee for protection against infectious materials. Next slide. We use PPE to protect ourselves, our residents, and others in the process of performing care, including protection from dangerous or infectious substances. Next slide. Listed here are types of PPE commonly used by healthcare providers. Gloves are the most common type of PPE that is used in healthcare settings. All of these serve to help keep us safe. Next slide. Based upon the CDC guidelines, PPE is to be used every day by all healthcare personnel to protect themselves, residents, and others when providing care. This also includes your activities personnel, environmental services, dietary, administrative staff, hospice, repairmen, etc. There are instances where residents must wear PPE for protection, including attending doctor's appointments. More detailed information is available at the CDC link provided here under the tab Infection Control Guidance. Next slide. PPE must be donned correctly before entering the resident area and must remain in place and be worn correctly for the duration of work in potentially contaminated areas. PPE should not be adjusted, such as retying the gown, adjusting the respirator or face mask during resident care, and must be removed slowly and deliberately in a sequence that prevents self-contamination. Have a PPE buddy system in case assistance is needed. A step-by-step process should be developed and used during training and during resident care. Next slide. For more information on proper use of PPE, I highly recommend the CDC link. There are posters in both English and Spanish that can be used for staff education, as well as videos for education purposes. I'll go over some of their guidance now. Next slide. Standard precautions are used for all resident care. Transmission-based precautions are used when caring for those with known or suspected COVID-19 infection. Proper donning, doffing, and use is necessary to prevent self and cross-contamination, so I'll go over those in a little more detail. Next slide. More than one donning method may be acceptable. Training and practice using your facility's procedure is critical. This is one example of proper donning. Identify and gather the proper PPE to don. Ensure that the choice of gown size is correct. Perform hand hygiene. Put on isolation gown. Tie all the ties on the gown. Assistance may be needed by your PPE buddy. Put on your N95 filtering face piece respirator or use a face mask if a respirator is not available. If the respirator has a nose piece, it should be fitted to the nose with both hands, not bent or tilted. Do not pinch the nose piece with one hand. Respirator or face mask should extend under the chin. Both your mouth and nose should be protected. Do not wear the respirator or face mask under your chin or store in your pocket between residents. Next, put on your face shield or goggles. When wearing a respirator, select the proper eye protection to ensure that the respirator does not interfere with the correct positioning of the eye protection, and the eye protection does not affect the fit or seal of the respirator. Face shields provide full face coverage. Goggles are also an excellent protection for the eyes, but fogging is common. Next, put on gloves. Gloves should cover the cuff or wrist of the gown. Now you're ready to enter the resident area to provide care. Be aware of your surroundings and what you're touching. Next slide. This picture from CDC shows fully and appropriately donned PPE. Next slide. Removing PPE, also known as doffing, is an equally important practice to prevent self or cross-contamination. Start with removing gloves. Ensure glove removal does not cause additional contamination of the hands. Next, remove the gown. Untie all ties or unsnap all buttons. Some gown ties can be broken rather than untied. Do so in a gentle manner, avoiding a forceful movement. Reach up to the shoulders and carefully pull the gown down and away from the body. Rolling the gown down is an acceptable practice. Dispose in an appropriate receptacle. Exit the room or area and perform hand hygiene. Carefully wash all hand surfaces for 20 seconds and don't forget the thumbs. Carefully remove the face shield or goggles by grabbing the strap and pulling upward and away from the head. Do not touch the front of the face shield or goggles. Remove and discard the respirator or face mask. Do not touch the front of the respirator or face mask. Perform hand hygiene after removing the respirator or face mask and before putting it on again if your workplace is practicing reuse. Facilities implementing reuse or extended use of PPE will need to adjust their donning and doffing procedures to accommodate those practices. Again, the CDC link at the bottom of the slide has more information. Next slide. Again, an infographic from CDC with the information regarding removal or doffing of PPE. Next slide. Some tips regarding face masks. When you put on a face mask, perform hand hygiene and put the face mask on where it covers your mouth and nose fully. When wearing a face mask, don't wear it under your nose or mouth. Don't cross the straps or allow them to hang down, and don't touch or adjust your face mask without performing hand hygiene before and after. Don't wear your face mask on top of your head, around your neck, or threaded through your arm. When you remove your face mask, clean your hands and remove by touching only the straps or ties. Perform hand hygiene again. Next slide. Again, a CDC infographic on these face mask recommendations. Next slide. Because there are often questions regarding optimizing PPE when there are supply shortages, And due to our time constraints here, I've added additional resources here from CDC regarding this. Next slide. And Lisa, I'll turn it back over to you.
Thank you so much, Susan. And actually, this is Angel Davis from CMS. So now we would like to conduct an open discussion and Q&A session. So to submit a question, click on the Q&A tab at the bottom of your screen and type in your question. Please be aware we will get to as many questions as we can in the time allotted. If we do not get to your question, we will answer any remaining questions after the event and post those to our QIOprogram.org website. As a reminder, along with the speakers today, we have Dr. Namali Stone from the CDC and Megan Hayden from the Division of Nursing Homes and CMS available to answer questions as well. I would also like to remind you to complete the post-event survey. The link will be posted in the Q&A box during the open discussion and will also be available immediately after the conclusion of today's training. So our first question to the panel is, if our facility does not have ventilators and have eliminated all aerosols, is an N95 mask warranted, or should we have them immediately available in the event of a code blue?
Hi, Angel. This is Namali Stone. There are actually a couple of different questions about face masks, respirators, and eye protection. So I'm going to try to touch on a little bit of all of them while we talk through this answer. So the recommendation when you're delivering care for a COVID positive resident is to use an N95 respirator, ideally fit tested, but we recognize that fit testing programs are really hard to get established, and there are a lot of supply problems with those as well right now. But the recommendation is that you use a N95 respirator if you have them available, and only use a face mask if there aren't N90 respirators available, in addition to using eye protection, which is either goggles or a face shield. So it's so even if you're not performing an aerosol generating procedure, if you have the supply and the equipment, then workers should be wearing N95 respirators during care, any type of care, close contact with a COVID positive resident. If you suspect somebody has COVID, then that recommendation still holds. So you continue to use N95 respirators if you have them available, along with full face protection, gowns and gloves. And so if you're putting people on an observation unit for 14-day quarantine, then it would be appropriate to use that full complement of PPE during care for those individuals. So if you're caring for somebody known to have COVID or suspected, and you're observing them, and that could include people who are exposed or people recently admitted, those all fall into category of using the full recommended PPE. And for your face protection, that's a respirator and eye protection, whether goggles or a face shield. Now, on non-COVID units, in environments where we're seeing the community prevalence of COVID cases rising, we are seeing a lot of introductions of COVID into nursing homes through asymptomatic healthcare workers. For that reason, and to add another layer of protection for the healthcare workers as well, we are recommending that you add eye protection to your resident care in in addition to the universal face mask. So it is coming up, and I know this has come up on other webinars we've hosted, that people are being asked to add eye protection, goggles or face shield, in addition to their face mask, even when caring for individuals who are not known to have COVID. And part of the reason is when you're in these high incidence areas and the cases are more prevalent in the community, we're trying to come up with additional protections to reduce exposure between caregivers and residents, and caregivers, staff to staff. And we've seen a lot of staff to staff transmission as well. So the eye protection, or face shield kind of do two things. They protect the mucous membranes of the eyes, which are vulnerable to viral transmission. Also, if you have a face shield on over your face mask, it's an additional barrier to keep people from touching their face mask. And one of the things we really worry about in terms of asymptomatic infected staff transmitting COVID to others is if they're touching their face mask, fidgeting, pulling it up and down, adjusting it, and not cleaning their hands immediately, they can cross-contaminate other surfaces, or their hands can be contaminated, and they can handle people or equipment. So that extra layer, if you have a face shield on, keeps your hands even farther away from the face. So those are some of the questions about masks and face protection. Hopefully that covers the scope of some of the other questions as well. Thanks, Angel.
Thanks, Namali. I've got a question that came in via email. The question is, can you summarize why the CDC shifted from 72 hours to 24 hours since last fever?
Yeah, I don't know that I can point to a specific paper to sort of explain that change in our guidance. So for those of you who may not have seen it yet, we have recently updated the discontinuation of transmission-based precaution guidance and return to work guidance for individuals with COVID infection. And one of the changes is to reduce the time of resolution of fever from 72 hours, which was actually what was presented in the slide deck, and was the previous recommendation, to 24 hours. 24 hours of resolved fever off of any antipyretics, any fever-reducing medications, plus improvement in symptoms, plus 10 days from the onset of symptoms, or one of the new additions is 20 days from the onset of illness if you had severe infection. I didn't actually answer the question because I can't give you a citation to explain it. I can say that our epidemiology team and our clinical team have continued to compile and review the data that we're learning about the virus and its transmission risk as we experience this and have more weeks and months into the pandemic. And so the papers that are describing the risk of transmission suggest that in mild, moderate illness, it's the duration, I guess, from onset of symptoms and the resolution of symptoms can be abbreviated. Thanks.
Thank you, Dr. Stone. Our next question is, how do you cohort residents in a long-term care facility with limited empty rooms? And the second question in that, how do you move and decontaminate all the residents' personal possessions and belongings during the move?
Hey, this is Molly.
Go ahead.
Sorry, I'm thinking it through.
No problem.
You know, the reality is that, you know, the person asking the question is completely right. When facilities start to go back to higher occupancy rates, this issue of cohorting becomes more challenged. And I think one of the real long-term issues that we need to figure out how to address based on this experience with COVID is going to be, how can we create space quickly or preserve space for cohorting unit when centers really need to maintain very, very high occupancy rates in order to be financially intact, you know. So that's a lot of issues to sort of contend with. What I have seen in a couple of centers that are kind of on the resolution side of their COVID experience, and they are now, most of their residents have resolved. They have very few, if any, cases active in the building. They have technically kind of, they're closing down their COVID units, but most of them are keeping in reserve a section of a hallway, if not a dedicated unit for now. But I do recognize that it is going to be a balance and a challenge in terms of needing to, admit and readmit residents and expand, go back to care and keeping that space available. I don't know. I know it's hard to get a dialogue going with you guys on the line, but if anybody has an experience, suggestions for how you've handled it that you want to put into the chat or send us through a question and answer so we can share it with the rest of the group, please do, because I do think this is really going to continue to be an issue that we need to think about, not just as, you have limited space for COVID care, but also as we start to go into the fall and we're starting to think about respiratory viruses and how are we going to manage the risk of more than one respiratory virus circulating in our center at the same time. Thank you for the question. Not an easy one to answer.
Thank you so much, Dr. Stone. Next slide, please. So we would like to thank you for your participation in today's call. Thank you to our speakers, and a special thanks as well to our CDC colleagues for joining us during the Q&A portion of the event. We hope you found value in the topics discussed. Please take a moment to complete the survey from today's event. You will be sent directly to the survey at the conclusion of the training presentation. The survey link can also be found in the Q&A box. And thank you again, and this concludes today's call.
Thank you for participating. You may now disconnect.